Hello, everyone, and welcome to today's webinar, Streamlining STI Testing at a Public Health Laboratory. I'm Cassie Saltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Abbott. To learn more, visit abbott.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. I'd like to now welcome our speaker, Dr. Godfred Masinde, Laboratory Director, San Francisco Public Health Laboratory. Dr. Masinde, you may now begin your presentation.
Thank you, Cassie. I hope everybody can hear me well. My presentation today, as Casey has said, is streamlining sexually transmitted infections, testing at a public health lab. And before I start, I would like to share with you my disclosures so that way everybody knows some of those disclosures are important before I begin the presentation. So I'll give you a second here, and then I'm moving on to my next slide. Okay, so today I'm going to be able to present to you how we did a study that will help us actually streamline our STD testing, because we have a lot of volume that we do every year. And I've divided my talk into 3 sections. I've looked at our San Francisco Public Health Lab testing, STI testing. Then we'll look at the volumes. Then we'll look at also the positivity rates, and then critical equipment that we are using in that. And then we'll move on to the case study that really gives us the root cause of what could make it better. And under that, we'll have some goals. We'll have the collection site study, laboratory study, and then summary of the findings. And finally, we'll have the acknowledgement of the team that participated in getting this study done. Our interest was just to make sure that we can learn whether there's something we can do better than what we are continuing to do. Okay. The next slide here, I want to be able to share with you our volumes, so you realize that we were interested in this study because of just how much volume we have. Therefore, when you make 10% mistakes, then you have tons of samples that either you have to not test, return, or just waste the kit. That's why it's extremely important for me to share with you our volumes. And as you can see, I try to give our volumes from 2018 to 2019 before the pandemic. And then after the pandemic, you will see 2020 all the way to 2022. And you can see our numbers. We had actually peaked in 2019. I think we had quite a lot of numbers going. And then after the pandemic, our volumes are starting now to come back up again. Hopefully, in 2022, we see them going up. And 2023, actually, when I show you, especially in the positivity rates, you'll see that we are actually going up pretty slowly, and hopefully we'll get there where we were before 2019. We want to do as much testing as we can. So this is our positivity. These are our positivity rates. So if you convert these rates, these positivity rates look less, but when you convert them against our numbers that I've just shown you, you'll have quite close to 4,000 to 5,000 people that are positive in a year, and those with an STD, those can actually convert into a lot of infections if you cannot be able to capture them and treat them. The only thing I wanted you to note from this slide is that as you go across, you'll see that 2018, 2019, it might not look very significant to your eye, but you will see that chlamydia was the positivity rate was higher. But then as we go across after the pandemic, you'll see that 2020 going on to now 2023 is actually showing the same trend. We are starting to see that chlamydia is the one that is higher. That gonorrhea is the one that is higher than chlamydia at the moment. And some of the reasons, I talked to our epidemiologists, they are feeling like there are clinics that we closed down that were more of the younger people visiting. And science says that a lot of the chlamydia infection is in the younger population, and the ones that were never closed were the ones for the adults and also our MSMs group. That's the reason why you are seeing that exchange in positivity. It might not look that big, but when you calculate in numbers, it's actually getting really big. Like when you see by 2021, you can see we are starting to see a big difference there. So that's why I wanted to share with you this, so you see dynamics that have changed because of just the pandemic. And before I move on to share with you the study, I would like to share with you just a few of our machines that we use mostly for our STD testing. And we have Abbott Alinity M, we have Hologic Panther, then we have the gold standard AIX 1000. So the gold standard, that's mainly our RPRs. That's the syphilis testing. But then Abbott and Hologic, those can do both CDGC, MGen, and TRIC at the same time, and also they can do HIV, HCV, and so on. So I just wanted to share, those are the critical equipment that do the high volumes that you have seen. And those were the numbers I showed you. Just keep note that those were numbers for only CDGC. We do a lot of other tests. We have HIV, we have syphilis, we have HCV, we have TB, we have other communicable diseases that we can share. So we have bigger numbers than that. But our interest was in chlamydia gonorrhea because that's our highest volume, and that's the reason why we are sharing with you this study. Okay. Of course, we want it to be data-based. We don't want to decide anything without data showing that actually this is what we can do. And mostly as a lab director, you want to be able to have data to decide which machine do I use? Do I bring in this instrument, or do I bring in this instrument? Looking at the pros and cons, because you are going to look at from the collection level all the way to the lab level. So you look at pre-analytical areas to analytical. So pre-analytical, I count it all the way from collection until it hits the lab, passes through our specimen receiving, then it goes into our areas for analysis. So it's important. We wanted to improve the workflow efficiencies in and outside the lab, and at the same time, we wanted to make sure that we look at the providers, see what we can do to be able to make it better. And our role in clinical outcome is to protect and promote the health of all San Franciscans. And this is what we wanted to do, is to get it right the first time, so we don't have no tests. We don't have to spend a lot of time calling to be able to correct errors or mistakes or information that is missing. So that's why we wanted to do this study, to find exactly what is the root cause. And then in the we wanted also to see the future. If we are growing, what do we need? We need capacity for the future. So that way we can expand service to meet needs for the community. Okay. So let us look at the workflow at the collection site. And that was where the study began. So that we start from, because when the mistake occurs at the collection site, it's going to transfer all the way to the lab, and then you'll end up just rejecting that sample, no test, or you'll have to make a phone call to correct some of the errors that you are missing. Okay. So collection kit analysis, that was the first part. What we wanted was to focus to the root cause of the current collection site issues, and those are quantified and linked to hands-on time. How much hands-on time do we take? And we did not intend to target any collection site as 5%. Rate was used to quantify hands-on costs for the sites where data is not available. So that's what we wanted to do, so that we can be able to make sure that we can do better estimate. As I said in my disclosures, we did some estimates also at the same time to give us an idea, because we might not have completely all the information. So we wanted to make sure, and then we just took one of our full-time employees to be $36 an hour, and then we go from there to analyze the data as we go through the study. Okay. These are some of the clinics that were visited, and you can be able to see that we didn't put the names, we just put as A, B, C, D, and so on. But you can be able to see the rates here, like the A, which is our city clinic. We didn't have a chance to do the errors and error rates, but we looked at the places where there's some clinics that had a lot of errors. What was the problem there? And therefore, we went through to be able to look at those. And when you look at site C, for example, that's 186, which has 2,600 specimens collected between September and December 2022 with 5% error rate, compared to, of course, G, which is our emergency room. And the emergency room has only 1.151 specimens, but the collection, the errors are 9%. So you can see that it doesn't go with how many samples you collect. It just depends on what kind of personnel, and everybody should know that in the emergency room, they change a lot of the personnel working there, that you cannot be able to completely train them, especially when you have a more complex collection kit. So those are some of what we wanted you to note just from these numbers, that they don't follow the numbers we have, but it just depends on the personnel you have. Do they have time to be trained before they use that collection kit if it's a little bit more complex? And those were some of the issues. We say 80% of the volume is collected from those 14 sites that we have shown, and there's no correlation between volume and error. That's what I wanted you to note from this. Okay. Then the next slide is just the kit analysis. We wanted to see kit issues. Is it the kit issues? Because we wanted to go back and say, what about the kit analysis? So we looked at the order has matching type and source. So you have to know the kit and the source you are collecting. You can't just collect a different source and use any type of kit. It's specific. So 20 main issues, categories that we wanted to look at. And most common problem is wrong collection kit followed by order mismatching. So you can be able to see that. So you can see that at least looking at all these different issue categories, you can see that we really needed to be able to look at a wrong collection kit and order mismatching source. That's the main one. So 11 categories, of course, as where you see here, for 82% of the issues. And then 33% of them, of course, are linked with the current collection kit that we are using, because it's a little bit more complex. So it's not one, you have to take time to be able to train the people to be able to use that kit. They can't just come in and then they are ready to go. So here I'm just sharing what we have at the current collection process. And you can see here, the slide is crowded, but I'm just trying to show you that there are so many steps that are done here. Look at the collection kit. We have 3 different collection kits. So if somebody's not trained, they're either going to put a different source in a different kit that is not correct, or they're just going to use a swab that is not the right one for the collection. So those are some of the things, and that will lead into rejection. Then you have to reject those samples when they reach the lab, and then you have to call, you have to make phone calls. So you have to have somebody again dedicated just for that. So I just wanted you to see that. I don't expect you to read all those. Of course, the goal here was just to make sure that the 3 collection kit, there is a major issue. So missing orders are major issues. Swab present, wrong swab, no leaks, staffing concerns, and then training. Like in this first clinic that we went in, it takes about 2 to 6 months for us to be able to have people trained there to use the device we are using presently. So it's a bit difficult to standardize and train the collection site staff. That's one of the difficult things. And so you can see that the pain point is inventory space was also a problem, but just the collection kits were the biggest problem for the mistakes we were getting. So that's the reason why we wanted to understand what is actually going on there. Because also now with the workforce problems, you might not get those employees all the time there. You might have to change employees, and taking 2 to 6 months to train really is a problem. You cannot be able to stop testing and train new people and then go from there. Okay. The next, here again, the same group, you can see if we can eliminate these 3 different specimen collection devices, then what will happen is that our rejection path we will become more successful, that we don't have to reject things. We don't have to reject the specimens when they come in because maybe they're in the wrong kit, wrong source, and or wrong swab. So those are some of the things. And we want to make sure that if those are eliminated, you can see that you save 30 minutes hands-on time per patient. So that's a lot of saving time. You can actually do a lot more patients than we are doing presently. And then, sorry, I have to push this back. So for the future, for future sample collection process, you will see that a single sample collection device will allow for a very simplified workflow, because that's what we are looking for. Because of workforce, lack of workforce, we have problems of just training people and staying there, and maybe they leave, then you have to train again. So using a simple collection device allows for simplified workflow. You can be able to easily train people when they come in as new people. You can easily not miss anything. The source is the same kit, uses the same source, uses the same different sources. So you are in good shape that you don't have to struggle, and then you eliminate that sample rejection rate due to wrong collection kit used. So it's important, because most of the important part is that if you have one device, then you don't have a problem. You don't have to train people. You just tell them chlamydia, gonorrhea, collecting that, and that's what they do. They go forward and do that. Presently, when you look at, presently when you look at, let me go back. Sorry. Presently, when you look at the way the collection sites, when we look at the different kits, there are those 3 different kits, and then you find that you have to again do the sorting, and sometimes, of course, if you punch the foil, it will, because aluminum foil will be able to break, so you have leaks. But if you have, like for Alinity M solution, you have only 1 kit, and that 1 kit has more of these pierceable caps that are more solid. You don't have to worry about the leakage, but also you don't have to worry about training people for each different kit for each source. That way, it gives the collection team an easy way of, somebody comes in, you just give them that 1 kit and say chlamydia, gonorrhea in all sources, please collect in this kit. So you don't have to really train, especially emergency room. That's really useful, where the volume is, where the patient traffic is a lot. You need that to be able to help. So that's the part of just reviewing the collection sites. And let us be able now to look at, let us be able now to look at the lab. When it comes into the lab, that's one of the key things that we now look at, because if the mistake was made at the collection site, that mistake won't go away. You just know that you are going to end up with it in the lab before even you start testing the pre-analytical. When you go into specimen receiving, you have to sort out and make sure that everything is as needed. So you can see there are a lot of things that needs to be done. And during the sorting time presently, there's extensive sorting to separate different sources and tests, then batching and then racking, which increases hands-on time, missing information or wrong kit used. It's a lot of time of dedicated staff to call and get information, and also inform the clinics to reflect, to recollect or find missing information. So it increases turnaround time a lot. And it increases also the cost of the FTE and waste of kits. Of course, that kit is wasted. They have to use a new kit. So this is what I'm explaining here, that we want to be able to eliminate those red areas. And if those are eliminated, you see that we have a lot of time to be able to spare. And of course, in the long run, the proper staffing, so you don't have to have someone to keep calling from the lab. And you don't have to do that extensive sorting, verifying, batching, and more sorting again. Okay. Then the next, this is of course, the Alinity M process, which is much simpler. And you can see, I just want you to see, this is a crowded slide. I just want you to see that there's potential for 35 annual hands-on time hours saved, and then potential for 34 annual hours or hands-on time hours saved. So you can see these areas, you can be able to actually not have any problem, because you eliminate them. You'll have you are creating orders manually, which increases hands-on time, but you will also be saved by automatic scan. of the system, and the system also has auto verification. Will eliminate time to print and check each test, and then remote one by one. So turnaround time will be reduced, and the FTE can handle other tasks. For example, they can be able to go in and do some reports and do other things instead of just waiting there and working on these samples. And because we have a very high volume, as I mentioned for everyone, that volume you can take hours to be able just to report those samples, or 500 samples per day. You'll be able to you take a lot of time. But if you have an auto verification, especially for the negatives, you can just be able to go in only for the positives, which will be fewer. So which will be a better system to be able to go. Okay. And then the next process, again, you can see those areas that we can be able to eliminate in the lab. So that way you save 10 minutes here, 20 minutes here, and in the long run, you find that you actually end up to reduce a lot of hands-on time, reduce potential for errors, and then you also have fast turnaround time. That's the key part. And now with, of course, the lack of workforce in the public health labs, you really want something that you'll have one micro can do a number of things. They can be able to multitask easily if your system is automated, other than sit on one and then go to another one. They will not be able, and it also makes them tired and it takes longer for them. So it's important, if you shorten your time, shorten some things, make them auto, you can be able to utilize one microbiologist, especially for California, where you need a trained microbiologist to be able to result and also be able to load the systems, to the instruments to run. Okay, so here we are looking at the Alinity M molecular testing process, and it's a one standardized auto workflow in the instrument with the STI multiplex. This is we are doing actually more with less, and that's what we want because of just the lack of workforce. We want to be able to do more. One micro can run different instruments at the same time, can set up the Alinity M, can go and set up another system, and everything just runs at the same time with one micro. And then reporting, again, the same thing with auto reporting. So the process is much easier, so that you just get a consolidated system. You'll be able to get all these results at a go. Then you have the random access where you can keep loading at the same time as you go. And then again, the turnaround time is less than 115 minutes. And you see when I show you the turnaround time, it's really quick. You can be able to report a lot of them on the same day, other than the next day. So it's good. And also the volume that you can be able to test. Even with our volume now, we'll end up with the more volume to be able to expand in the future if we need to. And that's important, that we can be able to expand when we need to, because as you see, the testing is coming back after COVID, so we might be able to have more and more more people coming back to the clinics, and then we'll be able to need more testing, and so we need that capacity to be able to test more. And then when we run the test in the lab, auto verification with the Alinity M will really be good, because it will make sure that you don't have to go in for negatives, because the majority will be negatives. You don't have to do anything. They auto verify, and then they go into the system, and then go into a LIMS system, then into EPIC system, and then the providers will be able to utilize those results. And then you can work only on the positives, which will take you a shorter time because you have fewer there. So that's one of the advantages of Alinity M 4-plex system, that will really help you to be able to do more with less. So you have less personnel, you can be able to run a little bit more assays. Random access, you can load more than one assay at the same time. Okay. We are looking at the future state impact, and one of the ways we want is to see how it will affect us in the future. If we can be able to get this study, get the data that we have now, and then be able to utilize this, what will we get? What are the achievements we'll get? And one of the key things, hands-on time is key. And hands-on time, you can see current state, we are using about 610 hours, and with Alinity M, we'll use about 376. So you have potential to reduce your turnaround time. We reduce the turnaround time through the entire process, from specimen collection, testing, auto resulting, and reduce turnaround time for patient and clinician. So automation reduces human errors and also improves quality of your results, as there will be less mistakes. Even when you have a trained micro, if they are working on those many samples, you know that you'll have some mistakes, and you'll also save the full time, the FTE time, and they can do something else. So that's key with the lack of staff at the moment in public health. I don't know who has all the staffing, but at the moment we all have problems in staffing. I think we can't be able to have full staff, but you can see potentially you'll free up time for your micro to do other things, can do paperwork, can do troubleshooting, can do other projects, SOP reviews and verifications and whatnot. They can be able to do that because they have the extra time to write the reports, maybe corrective action reports and other things. They can be able to do that. But potentially you can see you save quite a bit of funds. Yearly, in 5 years, you can save like 87,000, which is useful because you can turn around, use that to be able to test more patients. Yeah. So it's very good. It ends up, at least you save about 38% of hands-on. Okay. Turnaround time, we just want to show what you'll get with the Alinity M. This is calculated as samples arrive in the lab, not from the time the sample is collected, but this when they arrive in the lab. You can be able, if you look at this blue line at the very beginning, the blue graph going up, you can have all the assays running on the instrument, and you find that you can report within 9 hours, quite a lot of them. But 95% of the samples are tested are reported within the first 110 hours. So it's really going to give us a good turnaround time, reported within 9 hours. But presently, of course, we are about 110 hours, which means next day reporting instead of the same day. So potentially we will improve the turnaround time by 89%. So you are going to be able to reduce that time instead of doing the 110 hours, which is always the next day. You can actually do some start testing there. If we have patients like already in the hospital that need results, you can be able to send them or in the clinic, depending on where they are. So that would be really helpful. Yeah. Okay, this slide, I just wanted to show you that with the process we're using now, we have so much instructions that somebody has to be able to read through all those instructions before they can be able to actually start using that kit that we're using presently to be able to collect the specimen. But with Alinity M, of course, we have that single kit. So you can put the urine, you can put all the urine gentle or other types of specimens. So, and then the PSable caps are much better for they minimize any leakage and contamination. So that's really very good. And then you can be able to eliminate a lot of the collection, the provider collection site mistakes, and also in the lab, when it comes in the lab, there's nothing that transfers into the lab, which is a very good thing. So you reduce your time. So if you eliminate that, then you just have that simple process there, so that you can be able to easily train somebody to be able to collect the samples and then be able to move them on to the next level from the provider into the lab with less mistakes, less calls to make, less no tests to make, and then you'll be able to be more efficient on your time, and also just the turnaround to the patient treatment. The physician and patient treatment, they will be treated much faster. And with the SDGs, of course, we are going to reduce the transmission in the community. That's our aim, just to keep San Franciscans healthy. Okay, this is just to. Oh, sorry, I went back. Let me go back here. Okay, so you eliminate all that, and then you can look at the capacity. The capacity here analysis, you will see that we still have a lot of capacity for the future. So we'll average about 92 average daily spare capacity on 8 hours. So if we end up getting more testing as we are anticipating, as COVID goes away, you find that we can be able to test more because we have the capacity to do that. So you can see what we are doing, like what they tested the time the study was done. And then you can see that we can be able to have extra to run if we need to. So it's something that you can look forward to growing in the future. So you have to always look at the future. Don't look at now, because testing is increasing. SDIs are increasing. They are not actually reducing. So we need just to be very vigilant to make sure that we can be able to test everybody that comes in the door, to make sure that we don't delay also, so that we can cap transmission to the next person. Okay. And these are the collection kit issue analysis, and you can see 89 sites of potential hands-on time cost of about 5,000, which might not look a lot, but when you look at the testing, you are paying a test for $20 a test. That can give you quite a few more extra tests. 15 sites, of course, potential hands-on cost is about 23,176, which is again looking at this and streamlining. You save this money and you can be able to utilize that for testing more of the specimens that you can get from patients. Otherwise, testing is still becomes expensive when you're doing such high volumes like what we have presently. Okay, so let's give you a kind of summary to be able to see what this study gave us. We have more data, but I try to make sure I just give you data that can make sense here for now, but we have a lot more data that we didn't just include here that we have. So we just want to summarize for you to be able to see how that data has actually been summarized and how we can utilize it. And I'll just tell you that also what we are thinking ourselves, because we carry both systems. So we will be able to be looking at where the opportunities that we can be able to grow in the future. And then finally, you can see my summary of the impact of the outcomes and proposed state to enable San Francisco Laboratory to contribute to achieving measurable better healthcare outcomes. Because what we are talking here is you are looking at turnaround time, you are looking at the patient being treated time, because a lot of times when it takes too long, to turnaround time becomes too long, then you might not find that patient, especially with our population where you're having the homeless and people passing through the jails and whatnot. You might not be able to find that person to treat them. So it's good to have faster turnaround time for the clinicians to be able to treat them on time. And that's why you see that there's potential 33% potential to reduce. There is a 33%. I hope you are seeing my summary here on my last slide. Okay. So as you look at this, you can see that potentially 38% for reduction on hands-on time. So your most trained staff can be able to do something else within those hours. The annual labor days saved at about 38. You can be able to see that in 5 years, you save almost 113,000, and you can be able to actually use that to be able to do testing, test more tests. And then again, potential hands-on savings from specimen collection. Look at just specimen collection. That's again a good saving that you can get more kits and do more collections. And so in the long run, you end up with about 89% potential improvement on your turnaround time, which is really what you want. And with random access and auto verification, you are going to be able to actually get your turnaround time really good so that you can get the patients treated as fast as possible. That's one of the key things. So in essence, what I'm saying is that when you are looking at an instrument and you want to change this instrument, or you want to use a different instrument, or you have two instruments that you have together there in the lab, how do I use them economically to be able to help the lab, especially reducing the turnaround time? Because with the SDDs, we want to be able to reduce turnaround time and then be able to also have the treatment done quickly, so that this infected person does not move into the community and start infecting more people. So it's key that you want to utilize them in an economical way. You look at which one will be able to give me faster turnaround time, which one will give me less hands-on, so that I can be able to utilize my most trained or specialized micros or microbiologists to do more complex stuff, other than stay to do this when the machines can be able to do them. So those are some of the things that we ask ourselves, and we are presently studying this. We are presently studying this. We have both systems then we can be able to see where we utilize them carefully, looking at the data and the errors that were made. Where can we utilize which instrument can we utilize? So that's one of the key things from this study that we got. As you can see, the summary is this is the beauty of this study, is just how each step will be improved, and lack of staff both at the collection sites and the lab. So more can be done with less, and the savings can be plowed back in. So there's a kit of there's a lot of potential and benefits, as you can see in the diagram. Savings on hands-on time, at the same time labor and turnaround time that will be very useful for us with the workforce, lack of workforce, and also just treatment of the people infected, because we could have 4,000 to 5,000 people that are infected in a year, as you can see from the numbers if you calculate from the 4% and 5% and so on. So next, I just want to kind of acknowledge ABIT. That's the group that did the study, and of course, including the ABIT's solution designs team, and then Alina from our lab that actually worked with the team to make sure that this happens. And I have other slides that you can look at your own time. The intended use, the assay, how it works on Alinity app. That's what I wanted to show you. So that's the end of my presentation. Thank you very much.
Thank you, Dr. Masinde, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located in the far left of your screen. We'll answer as many questions as we have time for. Now let's go ahead and get started. Our first question is, can you comment on why your gonorrhea positivity rate is higher than your chlamydia positivity? Also, do you observe co-infection with the Trichomonas vaginalis and what that positivity looks like?
Okay, so the first one is just that I'm writing that. Let's go ahead, Cassie. Can you ask again, please? Just one by one.
Sure. Can you comment on why your gonorrhea positivity rate is higher than your chlamydia positivity?
Yes, one of the key things, as I explained during COVID, we closed some of the clinics, and those clinics we closed mostly were for younger people, not the older adults. I have the epidemiologists told me that that's what we know, that they closed those because they work with those clinics very closely, and most of the ones that remained were the ones for adults and the MSM group in our population. So, and the chlamydia has more affinity for younger people in the infection, that's what he said, than the older groups. So that's the reason why there's an interchange from the before pandemic was more in the younger people, and that's why we had more numbers. And then after that, it's more in the less, because those younger people are not coming in as much to be seen, because those clinics are not there. We know they are going maybe somewhere else, but we are not maybe capturing that. They might be going somewhere else, so we don't capture it. But we still have our normal adults and the MSMs that go in, and those will have more likely to have gonorrhea than chlamydia. That's why you see the exchange there. It might look small, but the numbers are big from what we do.
Thank you. The second part of that is, do you observe co-infection with Trichomonas vaginalis and what that positivity looks like?
I will not tell you the positivity, but I know that we have a lot of co-infections. I can be able to answer that. Maybe if the send an email, I'll be able to check that up in our systems, and then I can be able to send you that rates that we see for co-infections with the either MGen or a trick with the CDGC.
Okay. Our next question that we have here, do you test for Trichomonas vaginalis and Mycoplasma genitalium?
Yes, we do. We test for Trichomonas, and we also test for MGen.
Okay. Do you foresee additional workflow streamlining with testing Trichomonas vaginalis and Mycoplasma genitalium in your future sample collection and processing?
Yeah, I think that because we use the same, for example, what we are using present will be the same kit. So you use actually the same specimen to be able to collect. So if you streamline the sample collection, then you have streamlined also for MGN and for trick at the same time. So it will actually be a multi-purpose streamlining that will help us to be able to streamline all the 4 that we test at the moment: CDGC, MGN, and trick.
Okay, thank you. Can you provide additional detail on how the team carried out the collection kit swap out at your collection sites?
We didn't swap yet. It was just a root cause study. So they are not swapped yet. This is our data that we just got. It's actually not long ago, so it's off the hot. It's hot off the plate. So we are looking at it and seeing what can we do with this data now that we have it and it's giving us these savings and that turnaround time and so on. See how we utilize it, because we have both systems. We can be able to utilize each system where it works best if we need to implement. But we are still looking at the data yet. We haven't come up with the solution yet.
Okay, thank you. We do have one that's a request. We have an audience member requesting to view the lab machine slide again. So if we can just go back to that slide and leave that up to display. If you go to that slide and push to audience.
Okay, let me go back. Just a minute here. Want to see the machines, the equipment?
The lab machine slide, yes. Mm-hmm.
Yeah. Do you see
Perfect.
that?
Yes.
Yeah.
So we'll leave that up while we answer our next question here.
Yeah.
Our next question is, does error rate on slide 12 equal a misdiagnosis, or was a result just not able to be obtained?
Okay, that's not very specific. Can you ask that again?
Does error rate on slide 12 equal a misdiagnosis, or was a result just not able to be obtained?
No, normally when there's an error, that sample is most likely is rejected. So we don't go on to report it. It has to be either recollected, or if it's missing some information, we have to get that information first before we test, because we are clear certified lab, so we have to follow the rules. You can't just go on and test without making sure that you have all the information needed on that patient, and then you can go ahead. And if it's collected in the wrong kit, of course you have to reject that. You can't test that. There's no way you can solve that other than going back to the patient and saying, hey, we need to recollect. That's why I talked about time for just calling to correct errors, but also calling to make sure that the patient can be recollected, because you never know whether that patient is positive. So you might just miss that in the community. So anything that has an error, if it's not corrected, it has to be recollected from the beginning and come backwards into the lab again.
Okay, thank you. So it looks like we have just one more question here. Did you compare with the Hologic Panther system? I apologize if I said that wrong.
Yeah, Hologic Panther. Yeah. I think the systems we have, and I'll say it here, I know I didn't mention it last time before, but this is the systems we are looking at here is Hologic Panther and Abbott M. Those are the 2 systems that we have, and we are going to continue using both systems because there are advantages and disadvantages looking at our data that we have presently.
Wonderful, thank you. Before we go, did you have any final comments that you wish to lend upon our audience?
No, I think the key part, what I've been trying to do is to let lab directors know, or managers or supervisors that make decisions on equipment, to be able to have data that they can be able to look at before they make a decision on what kind of instrument I want in my lab. Look at present and future. Don't just look at present, or don't look at the price and say, oh yeah, I'll go with this one. My main aim is to make sure that we get some educated data. And most of these companies are free teams that can do a study for you, and you can give them the goals you want to achieve, so that they can be able to do a study that you can make decisions out of data, other than just thinking about it or looking at price. Price alone doesn't help you become more efficient, especially in the world where now we don't have enough personnel, we don't have enough funding for public health. So it's key you have the data before you make that decision.
Thank you again, Dr. Masinde, for your time today and for your important research. We would also like to thank LabRoots and our sponsor, Abbott, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions that we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.
Goodbye. Thank you.